APGO Educational Topic Number 9, Preconception Care. Meet our patient, young, reproductive aged. She is a common patient in all medical and surgical scenarios. It is always important to consider the likelihood of pregnancy in all of our reproductive aged patients. The objectives of this video are to describe how certain medical conditions affect pregnancy, to describe how pregnancy affects certain medical conditions, to assess a patient's genetic risk as well as a father's genetic risk with regards to pregnancy, to describe genetic screening options in pregnancy, to recognize a patient's risk of substance abuse and intimate partner violence and explain how this would be addressed with a patient, to appraise a patient's nutritional status and make recommendations to the patient on nutrition and exercise, to assess a patient's medications, immunizations, and environmental hazards in pregnancy, to identify appropriate folic acid intake, and to identify ethical issues associated with prenatal genetic screening and diagnostic tests. Many of our patients see their obstetrician gynecologist when they are already pregnant. In a perfect world, Ms. Young would come in for a preconception counseling visit before she became pregnant, especially if she has pre-existing medical conditions such as diabetes. Why is this important? Let's look at fetal malformation rates and their relationship to maternal hemoglobin A1C levels. At a hemoglobin A1C level of less than 7, the fetal malformation rate is the same as baseline. At 7.2 to 9.1, there is a 14% rate. At 9.2 to 11.1, there is a 23% rate. And if the hemoglobin A1C is greater than 11.2, there is a 25% fetal malformation rate. Of the diabetic-related fetal malformations, cardiovascular malformations are the most common, followed by central nervous system, then gastrointestinal, genitourinary, and skeletal malformations. In addition, if a diabetic woman's hemoglobin A1C level is 11, there is a 44% miscarriage rate. Remember that organ formation occurs at approximately 3 to 10 weeks estimated gestational age, and fewer than 30% of diabetic women seek preconception counseling. A savvy endocrinologist or primary care doctor should therefore always talk to their young reproductive age women about contraception and risk of pregnancy, especially if glucose control is an issue. If Young came in for a preconception counseling visit, what should we address? If she has medical issues, we need to talk about optimizing control of the disease processes. Let's start by discussing systemic lupus erythematous, or SLE. Ideally, pregnancy should occur during a period of disease quiescence for at least 6 months prior to conception. If her SLE is active at the time of conception, this is a strong predictor of adverse maternal and obstetrical complications. All of her SLE medications need to be reviewed and adjusted prior to conception, with the goal of maintaining disease control while maximizing safety profiles. Preconception counseling with SLE is thus especially important. Next, let us discuss if Young had hypertension. There are several key issues pertaining to hypertension and pregnancy planning. First, blood pressure classifications. We classify hypertensive pregnant women into 3 classes: normal with blood pressures less than 140/90, mild to moderate hypertension with systolics of 140 to 159 over diastolics of 90/109, and severe hypertension is greater than a systolic of 160 and a diastolic of 90. We know that treating severe hypertension leads to a reduction in stroke risk. There is an unclear benefit of treating mild to moderate hypertension, for there needs to be a balance for lowering maternal blood pressure too much reduces placental perfusion. The medication classifications of ACE inhibitors, angiotensin II receptor blockers, and direct renin inhibitors are contraindicated during all stages of pregnancy. Methyldopa and labetalol are safe and commonly used during pregnancy. Pre-pregnancy hypertension, otherwise known as chronic hypertension, is associated with greater risks during pregnancy of superimposed preeclampsia, placental abruption, and fetal growth restriction. If Young has diabetes, in addition to the fetal issues we discussed earlier in this video, pregnancy has been associated with exacerbation of many disease-related complications. Poorly controlled pregestational diabetes can lead to serious end organ damage that could become eventually life-threatening. For example, diabetic nephropathy, diabetic retinopathy, and chronic hypertension. The good news is that perinatal mortality has decreased markedly in recent years because of the ability to achieve glucose control with medical therapy, either with insulin or oral hypoglycemic agents. Going back to our preconception counseling checklist, we've discussed some key medical issues that should be discussed. What else should we talk about? Infectious disease issues. Vaccines. Live vaccines cannot be administered during pregnancy, so the preconception counseling visit is an ideal time to offer vaccinations for varicella and or rubella if a woman is not immune. In addition, consider the pertussis and hepatitis B vaccines. Additional screening issues to consider would be HIV. All pregnant women and women planning a pregnancy should be counseled about being tested for HIV, in addition screened for other sexually transmitted diseases. Also, women who are trying to conceive should minimize exposure to outdoor cat feces secondary to the risk of exposure to toxoplasmosis. During the preconception counseling visit, we should also discuss genetic screening. The genetic disorders are based on the ethnic and racial background of our patients. Sickle hemoglobinopathies are more common in African descent, beta thalassemias are more common in Mediterranean, Southeast Asian, and African descent, and alpha thalassemias are more common in Southeast Asian, Mediterranean, and African descent. Tay-Sachs disease is more common in Ashkenazi Jewish, French Canadians, and Cajun descent. Canavan disease and familial dysautonomia are more common in Ashkenazi Jewish descent, and cystic fibrosis is more common in Caucasians of European and Ashkenazi descent. Let's discuss what would happen if young tested positive for one of these genetic disorders, for example, cystic fibrosis. Since cystic fibrosis is an autosomal recessive disorder, and we find that she is a carrier, denoted here with a capital C, lowercase c, then the next step is to test the father of the baby for cystic fibrosis. If young is already pregnant, it is important to have a private conversation with her to confirm the paternity of the pregnancy. If the father of the baby also tests positive as a carrier for cystic fibrosis, so both parents are carriers big C, little c, then 1/4 of their future pregnancies would have a chance of inheriting both genes, little c, and would thus be affected with cystic fibrosis. If preconception testing reveals that young and her partner are both carriers, then one of their options is pre-implantation genetic diagnosis. This is a process by which in vitro fertilization is used to create an embryo, and then this embryo can be tested for cystic fibrosis prior to being implanted. Alternatively, young and her partner can conceive naturally, and the fetus can be tested for cystic fibrosis with a chorionic villus sampling or amniocentesis procedure. This can lead to very wrenching decisions for parents about whether to carry or terminate a pregnancy if the fetus is found to be affected. Continuing to move down our preconception counseling visit checklist, folic acid supplementation. All pregnant women and women trying to conceive should take at least 0.4 milligrams of folic acid daily, and women should take 4 grams daily if they have had a prior neural tube defect affected pregnancy. Let's now discuss the importance of intimate partner violence screening. Intimate partner violence is estimated to affect as many as 324,000 pregnant women per year. There is a growing body of research on the connection between relationship violence and poor reproductive health care outcomes for women. Before and during a pregnancy are opportunities for the patient to begin developing trust with a healthcare provider. Lastly, we will conclude the discussion about preconception counseling with the topics of nutrition and obesity, counseling women about the importance of exercise and balanced nutrition in the preconception time can lead to healthier habits that can be more easily adapted during pregnancy and the postpartum time. This concludes the APGO video on preconception care. We have reviewed many aspects of preconception counseling and the importance of trying to optimize a woman's health for pregnancy and beyond.